good afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk, and if you are attending virtually, you may enter your question into the chat. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Abijha Boban. Dr. Boban is a third-year internal medicine resident here at Northeast Georgia Health System. Her passion lies within oncology, and she hopes to pursue a hematology-oncology fellowship next year. She will be speaking about how immunotherapy changed the world of oncology. Join me in welcoming Dr. Boban.
Hello, everyone. Thank you for coming to this speech that I have for you guys. But today I wanted to talk about how immunotherapy has made such a huge difference in this world of oncology. And I really thank my mentor, Dr. Andre Kalab, for helping me make this presentation. Like she said, I have no disclosures. Objectives, what I'm trying to explain today is to understand how immunotherapy works. I'm going to be focusing on immune checkpoint inhibitors as well as CAR T therapy, determining the significant survival benefit that's associated with immunotherapy, and then also to look at the side effects that are commonly seen with a lot of these medications. So why does it matter? Why should you care? Because today it is a current regimen in cancer therapy, and it is also the standard of care. So as physicians, we all should have a baseline understanding of a lot of these medications, as many of our patients will be on these medications. This data is from the WHO, and they looked at cancer death rates from 2012 till 2021. And as you can see in the US, it's steadily declining from cancer. Specifically, lung cancer, which is a very big focus in not only research, but also in the US, as it is one of the most common cancers, there has been significant decline in lung cancer death rates, mostly due to the significantly increased number of screenings that we do with the low-dose CTs and other screenings that we do, as well as the improvement in medication management with ICIs, which is the immune checkpoint inhibitors, CAR T therapies, and all these other medications we have. As you can see at the bottom, the national 5-year survival rate went up by 22% in just 5 years, from 2015 time period to 2021. And it's climbing even steadily higher. So more people are living longer, even with these cancers. So where did it all start? How did they come up with all of these medications? This is just a little example showing initially it started with a vaccine that I'm going to explain a little bit more about called the Coley's vaccine. From there, up till 1990s is when they even noticed checkpoint inhibitors. In 1986 is when they first noted cytokines that could be affecting cancer. So these are all very new findings. And the first cellular immunotherapy was approved in 2010. And the first checkpoint inhibitor was approved in 2011. So as you can see, none of these medications that I'm going to be talking and discussing today have been around that long. They're pretty new. However, we've had very good research and good clinical trials that have given us good information on how successful these are. So what is the Coley's toxin? So it was created by this orthopedic surgeon. His name is William Coley. He is known as the father of immunotherapy. And what was funny was he would be doing all these surgeries, and he noticed that the patients that had post-operative complications, had wound infections, and had sepsis and all the kind of strong reaction, they ended up having this regression in skin cancer, like skin tumors. And as you can see, the first image right there, this guy had this tumor after surgery. After he had a septic reaction post-surgery, went down. So he was curious about how that worked. So what he did was he injected a mix of live and inactivated bacteria. He induced sepsis in certain patients and saw this anti-tumor results. So that was the first first time anyone's ever kind of encountered something related to immunotherapy. So currently, we have multiple types of immunotherapy. They include monoclonal or therapeutic antibodies, which you might know as a lot of the mAbs, the CAR T therapy, also known as adoptive cell or immune cell therapy, checkpoint inhibitors, which I'll discuss more in detail, against CTL4, PD-L1, PD-1. There's cytokines, IL-2, interferon alpha immunotherapies, and then there's cancer vaccines. Right here, I'm going to discuss a little bit more about what checkpoint inhibitors are. Basically, it goes in and allows the T cells to recognize cancer cells. Prior to this immune checkpoint inhibitors, T cells are not able to recognize these cancer cells as foreign, and so they're not able to target and kill these cancer cells. But once these checkpoint inhibitors go and stop these ligands and allowing the T cells to see that these cancer cells are foreign and that I should go and attack them. And as you can see in the corner chart right there, there is multiple different targets that they have. They have the PD-L1, they have the anti-PD-L1, anti-PD-1, anti-CTLA4, and some of these are the examples. And you might know a lot of these by their brand names and not really as their generic, since a lot of these are still branded. Pembrolizumab you might know as Keytruda, and that's one of the most common ones that a lot of people know about. So a study that was done that looked at in JAMA, it looked at what percentage of cancer patients will actually benefit from these checkpoint inhibitor drugs. And it was a very significant, large amount of patients. It was about 40% of cancers could be impacted by these immunology drugs. However, there was only about less than 20% of those cancers specifically based on the mutations they had, would respond really well to these drugs. And this is only up to 2018, and I'm betting it's a lot higher by 2024 because of all the new drugs that I'll be discussing in a few minutes. And this is further just showing the patients that would have a better response, the cancers that would respond the best. But going on, let's look at Keytruda, since a lot of people know about this medication, and it was one of the most commonly used immunotherapy. And this is just up to 2019. And as you can see in this parentheses where it says ORR, that's the objective response rate. So that looks at the partial response as well as patients that had complete remission, that had complete improvement. So it's just a cumulative number of how the patients responded. And as you can see, some of them, I'll point to these, like right here in the initial stages, some of them just respond about 18%. But as you go more and more, like classic Hodgkin's lymphoma, it was a response rate of 71%. In metastatic Merkel cell carcinoma, 56%. One of the main ones that you'll notice is the non-small cell lung cancer that has gotten more and more expanded for the approval. Squamous cell cancer, a lot of the lung cancers have Keytruda as their main treatment. And then if you look at this next slide, it's the newer indications that have been in the past 5 years or so. So I didn't want to go in detail with the 2020 because there's a lot. In 2021, there was a lot. But a lot of these studies for pembrolizumab were under the Keynote trials, and they did hundreds and hundreds of Keynote trials where they tried pembrolizumab in various types of cancers, as well as patients, specific populations of mutations within those cancers. So as you can see, in March 21, 2022, there was the Keynote trial that showed for non-small cell lung cancer that showed objective response rate of 46%. And so this kind of goes on. It's expanding coverages for non-small cell lung cancer. And like you see, there's so many different cancers: metastatic biliary cancer, GI junction adenocarcinoma, endometrial carcinoma, cervical carcinoma, advanced bladder cancer, resectable non-small cell lung cancer, and malignant pleural mesothelioma that's metastatic. So the indications it's very, very wide. And this kind of just gives you a summary of all the cancers that it's currently approved for. And as you can see, it's a wide variety of cancers, from skins to lung cancers to biliary tracts, endometrial. So it covers pretty much all the various types. So one of the recent studies looked at Keytruda versus chemotherapy for PD-L1 positive non-small cell lung cancers. So some of these things, PD-L1, I'll be talking about MSIs, MMR, all of that stuff. I'm going to explain a little bit. But PD-L1, like I said earlier, is one of the main targets for a lot of these immunotherapies. And so as you can see, when they used pembrolizumab, which is Keytruda, versus chemotherapy, it was a significant change in how well they responded. But like this says, this is for patients that were PD-L1 positive. So that's something that they're screening patients for to make sure that they have this receptor that in their cancers. And so when they give this medication, the patients that have the PD-L1 are the ones that are responding. So if they don't do that testing, like I was speaking with someone earlier, they might not respond as much because they might not have this PD-L1 expression. In that case, Keytruda would not be as helpful. And as you can see right here, majority, can you see the, yeah. As you can see right here, when you gave the Keytruda, the hazard ratio was close to 0.1. Pretty much every category did way better with the Keytruda for the PD-L1 patients. Even in patients that were males, females, age didn't matter as much, smoking history didn't matter as much. They were all responsive. And if you look at brain mets, they were still responding. So even those patients that were metastatic were responding to Keytruda. So I'm going to tell you about a real life story of someone that had this amazing drug change their life. So it's a 64-year-old male. He had metastatic prostate cancer, and initially his PSA was 92. This is in 2015. They did a pelvic MRI. They showed it was extensive metastasis, extensive lymphadenopathy. He didn't have any bone involvement, thank God, but he was very metastatic. They initially tried a bunch of things, as you can see. They did leuprolon, they did bicalutamide, radiotherapy, they did a bunch of radiation, they did prednisone, all of that. He got better. However, it was not a complete remission. And then in 2018, he had another recurrence, and he was treated with cabazitaxel for 3 weeks with carboplatin later added. However, a few months later, in 2019, August, he came back with suspected cellulitis of the scrotum. I'm going to show a picture. If you're eating, you might want to stop. So this is what it looked like. This was how bad it had gone because of that cancer mets. Even though they were treating with a lot of the medications, he was still progressing. They did a scrotal biopsy, and it showed skin necrosis and focal tumor invasion by the prostate adenocarcinoma. There was no neuroendocrine or sarcomatoid features. They did a bunch of next generation sequencing, looked at the genes. It was negative for BRCA and all of those, some of the stuff that you see, but it was positive for P10 and P53, and it had high MSI or microsatellite instability, and they had deficient mismatch repair biomarkers. I'll talk about that in a second, what that means. And they had really high tumor mutational burden. He was at 44 mutations per megabase. So we tried Keytruda. PSA was 178 at that time. 3 cycles of Keytruda. Every 3 weeks, they were given 1, 2, 3, and he has been disease-free since November 2019 after he got those 3 doses. And this is him now. Well, not now, but in 2019, and he's been like this since then. So what is MMR? What is this microsatellite instability that we were talking about in that patient that had that? It's when basically what happens is they have impaired DNA mismatch repair mechanism, and it makes them respond in a better way to immunotherapy. They're known to show significant improvement when they are treated with immunotherapy. So when we are looking for cancer patients and have various cancers, one of the next generation sequencing we look for is this mismatch repair mechanism. If they are high in that, they have high tumor mutation burden, then it's a higher chance that these immunotherapy will be successful. This is most useful in colorectal cancer. This is present in about 15% of all colorectal cancer patients, this MSI. And so a lot of these medications work really well in those patients. And it's very common in Lynch syndrome. So just to talk about some of the most recent advances in immunotherapy, I want to talk about in locally advanced, mismatch repair deficient colon cancer. So in this case, these patients did not have as well MMR. They were previously untreated deficient MMR colon cancer patients. They were not metastatic. They were given this neoadjuvant nivolumab and ipilimumab, and it was amazing results. What you see right here, with these lines, each represents a patient. And each of these blue lines, the fact that they came down to 100, most of these, means they had complete pathological response, which means they were completely cured. There was a few that had a little bit, not as much, good response, but it was still better than, it was about 40%, not 100% like these people. But the majority, as you can see, 95% of the patients had major pathological response with this immunotherapy combination. And in the median follow-up of about 26 months, there was no patient in there that had disease recurrence. So this is unheard of in cancer. If you look back just 10 years, to have this kind of response it's amazing. It's not even something that they could even have predicted. So we're seeing these with newer and newer drugs. With the more trials we do, the more we're seeing in different types of a subpopulation where each of these drugs are so helpful. And this is just a little bit more of a breakdown of what I showed on the other slide. As you can see, patients that had Lynch syndrome had significant response. But if you look at like the age, it didn't really matter as much. If you look at all these things, it didn't really make much of a difference. The only thing that mattered was that they were MMR deficient patients, so dMMR. So they had more mismatch in their, more mutations and mismatches. So they had that significant response. Another big finding, this study was actually done at the Memorial Sloan Kettering. It was an amazing study. Although it didn't have as many patients as the other study earlier, it had about 12 patients, and it was advanced rectal cancers. And as you know, a lot of patients that go to Memorial Sloan Kettering, they've already tried, or they're usually more advanced. They're not the early stage people. They were treated with this new drug called dostarlimab, and they had no chemotherapy or surgery, just this immunotherapy, and 12 out of 12 had complete response. A follow-up 6 months later showed complete response, and none of them had regressed. Side effects, there weren't too many terrible side effects in this case. Most of them were just like fatigue, rash, the things that you notice usually with immunotherapy. But this one was very exciting for a lot of oncologists, because this was showing, like we saw earlier, that if we can find the right subpopulation for these immunotherapies, it can make a big difference in treatment. This is another one that looked at a recent study, is tumor response with semipilumab among patients with phase 2 study, metastatic cutaneous squamous cell carcinoma. So this is skin cancer, and the same study, same chart over here, where all of these findings from here on, it's like the people that responded really well. So all the purple are the ones that had complete or partial response. There was a few that did not have as good. They still had progression of disease, but the majority responded very well to this medication. And this is a PD-1 blockade. So we talked about a PD-L1. This is a PD-1. As you can see, the survival curve at 16 months, 50% were still alive after this immunotherapy. So significant, benefit, mortality benefit. And as you can see in this tumors, this is initially, and then after treatment, it improved. And this is another one that was initially after treatment. This is how it turned out. So pretty exciting stuff. Like I was talking about earlier, there were some populations that respond better than others. Who are they? Like I said, high microsatellite instability. MSI, high tumor mutational burden, so they're more likely to be mutating more. High PD-L1, especially if they have a PD-L1 greater than 50%. If you have worked with oncologists, you'll see that a lot of them, once they first meet a patient, they'll send some of their blood sample and their tumor out for next generation sequencing to make sure to find out all the different things that it has, all the mutational genetic markers that it has to help narrow down which chemotherapy to use. Some of the pros and cons, PD-L1 is very easily available, low cost. Disadvantage, it just depends on which sequencing method you use. Some of them don't have, it's not standardized, but we'll let the oncologist worry about that. And then MSI, MMR, same, different mutations have different companies that focus more on it. So that's just a little explanation of that. But it's great. Medication's great. It works. But we have to be careful of the side effects it has. Just because it can completely cure a few patients does not mean we can completely ignore all the side effects. Some of you have been with me when we encountered a patient that had myasthenia gravis after a Keytruda infusion. So there's a different side effects, and I'm going to go through them because as general internists, it's very important to recognize some of these side effects and to know what to do when you encounter these side effects. These are some of the immune-related events with Keytruda specifically, pembrolizumab. There was a lot of patients that had hypothyroidism. There was pneumonitis, hyperthyroidism, skin toxicities, all that stuff. But I'll go in more depth in the next few slides. Very common to see fatigue, nausea, vomiting, mouth sores, diarrhea, high blood pressure, peripheral edema, some fevers and chills after they get the infusion, some pain and weakness, some headache, rashes and itchings. And this kind of breaks down and shows the percentage. So pretty much 40%, up to 40% can feel fatigue. Up to 50% can have rashes, up to 30% can have diarrhea or colitis, and sometimes it's very severe and they're requiring glucocorticoids, and so on. This is just further explaining that. So what are some extrinsic mechanisms of resistance? You can have upregulated immune checkpoint expressions. You can have immunosuppressive cytokine release within the tumor. So a higher cytokine release, which is supposed to be helping, but you're having a higher suppression. T cell gets exhausted and they have phenotypic alterations. You can have increased immunosuppressive cell population because you're suppressing the immune system so it's not able to respond to other things, other infections and things like that. Intrinsic mechanism of resistance, you can have altered signaling pathways. So when you target one specific pathway, tumors are very smart in changing fast enough that they can get another signaling pathway. Limited mutational burden, de-differentiation of tumor, resulting in loss of neoantigen expression. So they might not have that antigen anymore. Loss of HLA expression, loss of antigen target, HLA expression, and escape mutations. So what are some structural cardiovascular things that you'll notice some of the side effects? You could have systolic dysfunction. You can have pericarditis, myocarditis, pericardial effusion, cardiac tamponades, stress-induced cardiomyopathies. And these are thought to happen because of similar T cell receptors that are in the tumor and the cardiac muscles. So that's one of the things that they're trying to improve, to focus on having these targets that are unique to cancer tumor cells and not in cardiac myocytes and other cells that are part of our body. Transducimab, which is a HER2 receptor blocker, is theorized to interfere with the HER2 signaling cascade, and they accumulate toxic metabolites and thus cause cardiac side effects. So that's just one way that it might cause. CAR T cell therapy, cytokine storm generated by reprogrammed T cells can cause a lot of cardiovascular collapse. Cytokine storm, I'm going to go in a little bit more in detail later. That's something that is fewer people have it that encounter it. It's very much more seen with CAR T cells, and when you do have it, it's very life-threatening. You can have common antigen between cardiac cells and tumor cells, like I said, like Titan is one of the examples. You can have antiarrhythmogenic adverse side effects like sixth sinus syndrome, and that's thought to have result of persistent myocarditis that disrupts cardiac conduction. And you can have lymphocytes infiltrate the SA node on the AV node, causing the sixth sinus syndrome. Some treatments are your usual antiarrhythmics. You might need a pacemaker, cessation of immunotherapy if you're in this kind of category. Some dermatologic, like I said, skin findings are very common. Macular papular rash or pruritus is most common. They can have other, even as bad as Stevens-Johnson syndrome, erythema multiforme, psoriasis, so a lot of autoimmune skin conditions. Some of the pathophysiology is kind of similar to what we said about cardiac. They cross-react. Antibodies directed against melanoma associated antigens can cross-react with melanocytes and normal melanocytes. Treatment, you can have topical or systemic corticosteroids. It depends on how bad the skin findings are. And they may require you to discontinue immunotherapy altogether if patient is having life-threatening things like Stevens-Johnson syndrome or something. These are some skin findings that are very common with these immunotherapies. As you can see, there's widespread rashes. A lot of patients will say, like, after the immunotherapy, like, I went home and I had rashes everywhere. A lot of times we pre-treat them before treatment with Benadryl and things if we are anticipating that there's someone who is more prone to get rashes and has allergies or had allergies the first time we tried it. Some endocrine adverse effects. Acute hypophysitis, thyroid dysfunction, those are some of the most common. Adrenal insufficiency, pancreatic dysfunctions, they can become a type 1 diabetic, DKA versus HHS, hypoparathyroidism. Like I said, they're mostly seen with immune checkpoint inhibitors, not as much with the CAR T cells. Some GI side effects, usually mild and transient, watery, non-bloody diarrhea. They can have colitis with bloody diarrhea and fever. Mouth ulcers are I've seen it very often with a lot of patients. Anal lesions like fistulas, abscess, or fissures. Asymptomatic elevation in LFT. So if you have a patient that comes in and you notice this LFT is being high, it might just be from the chemotherapy and it's nothing for us to really change or worry about. And then rarely gastritis, esophagitis. Treatment is mostly supportive. Give them antidiarrheals, fluids, electrolytes. Obviously, you want to rule out any kind of GI infection. They are immunocompromised patients, but as soon as you rule that out, make sure you give them good antidiarrheals. And then if it's severe, they might have to be hospitalized and receive steroids. Some neurological adverse effects. You can have inflammatory myopathies, you can have myasthenia gravis, vasculitis, small fiber sensory type neuropathies, immune-mediated neuropathies, and cranial mononeuropathies, even aseptic meningitis or encephalitis autoimmune. You can have MS. So like this kind of explains, it's a lot of autoimmune conditions that get triggered by these medications. Pathophysiology, obviously, increased T cell and macrophage activation, and that causes autoimmune damage to these nerves and stuff. Pulmonology adverse effects. Most of you have seen these before. Interstitial lung disease. Some of these patients come in. There was one patient in our ICU that was repeatedly there after getting one of the medications for his cancer, had interstitial lung disease. They can have concomitant pneumonitis. Obviously, treatment is steroids. At least 6 weeks, and then you have to discontinue the treatment. So that's pretty much my discussion about immune checkpoint inhibitors. Now I'm going to talk a little bit about CAR T cells, CAR T therapy. This figure kind of explains about how it works. Can I see a show of hands of who has heard of CAR T? Yeah, not a lot of people. That's what I thought. So it's one of the newer things that we're doing in immunotherapy, and it is amazing. It's not first line for almost anything. It's usually second line after you've tried and failed other things. But basically what they do is they take your blood, they take your T cells, they modify it with one of the receptors, usually the CD19, and area, the part of that, they modify it, they put it back in your body and let it fight within you as like a really strong fighter within you, the T cell. So that's kind of how CAR T cells work. So it's very cool. It's a new thing in immunotherapy. However, it's mostly used to treat hematologic malignancies. It's not as more as established in solid tumors, which I'll explain why in a little bit. As you can see, there's a T cell right here, and then there's the CAR, or the chimeric antigen receptor. And these are engineered synthetic receptors that they attach to the T cell, and they call it the CAR T cell, and that's what they put back into the patient. And it's, like I said, approved for several hematologic malignancies, lymphoblastic leukemia, diffuse large B-cell lymphoma. Very common one, like I said, is the CD19 CAR T cells against the B-cell malignancies. It was one of the first ones back in 2017. So like I said, it's also very new. These are some of the most common ones that we have. As you can see, it's not a whole lot that we have. There's only about 6 right here. There's a lot more in studies right now. Even Emory MCG in Georgia, as far as I know, they're doing a lot of studies with CAR T, newer drugs that they're working on. But as you can see, a majority of them are with CD19. That's the section, the antigen binding domain that they are changing. It's anti-CD19. And then there's few that's BCMA. And as you can see, these are all mostly hematologic malignancies. And most of these came about 2022, 2021 onwards. So this is just one of the ones that are more recent. Forgive my pronunciation, I'm not an oncologist yet, but Accreditation Statement, well, I'm not really sure how to say it, but it's a second-line therapy for large B-cell lymphoma, and this was published in New England Journal recently. And as you can see, they had a good amount of people, 180 people that received that versus a standard of care, which is chemotherapy, and then autologous stem cell transplant. A lot of these patients, if CAR T was not an option, the next option would have been stem cell transplant. So as you can see, these are patients that are very sick and don't have a lot of other options left. And it was an amazing difference. As you can see right here, Axel had about 8.3 event-free survival months compared to standard of care that was just 2 months. So that's just a graph that's just showing you right there, right at the bottom. And so side effects, like I said, the cytokine release syndrome, that's very life-threatening in these kind of CAR T therapy. There was about 6% that had that reaction. But the majority didn't have anything severe. It was just neutropenia, things like that were easily treated in the hospital. And compared to standard of care was just 41% versus CAR T had about 69%. So, you do have a lot more side effects with these, but they do make, that extra 6 months of life is a big deal for a person who has tried everything, is very, very sick and don't have a lot of other options. So it was a very great medication to have come about. Another one is, I'm going to butcher the name again, but it's also an anti-CD19 CAR T, Tisagenlecleucel, I'm not sure. But it's the same thing. It attacks the CD19 and is for patients with B-cell lymphoma. As you can see, standard of care had about the same as median. The survival benefits were about the same. Adverse effects were a little less than the standard of care. And as you can see, second line, it did not result in a longer event-free survival rate, but it did have less adverse effects. It's just something that you can try. If the standard of care is not working and they're progressing, you can try it. And this is the last one that I'm going to talk about for CAR T, is a treatment in lenalidomide refractory multiple myeloma. And as you can see, the patients that were treated with the cilta-cel group, they had much higher response and progression-free survival compared to the standard of care, about 60% versus about 20%. And this is just a breakdown. And you can see the complete response in the Citacel group, about 73% versus standard of care was 21%. Overall, about 84% responded, better than the standard of care. And side effects, obviously, it's still going to have a lot. And they specifically picked out the cytokine release syndrome. So it does have that side effect. But like I said, if you think about it pathophysiologically, it's basically working to make your immune system stronger. So you can anticipate that it's going to release a lot of cytokines because it's really fighting within yourself. So that's why in this case, about 76% of patients had some kind of cytokine release. And a single infusion, so it's just one infusion that they're getting following a bridging therapy, reduce the risk of disease progression and death in patients with lenalidomide refractory multiple myeloma. So these are patients, a lot of them have received 1 to 3 previous therapies and they have not worked. So they've already tried a lot and nothing has worked, and finally they go to CAR T. So what are some limitations? You can have antigen escape, which is basically complete or partial loss of target antigen expression. In that case, what they are trying to do in the newer studies are targeting like at least 2 antigens at the same time. So like multiple antigens. They have multiple ones that are in clinical trials right now that are doing that right now. Another one is off-target, on-target, off-tumor. So tumor antigens expressed, like we talked about earlier, in tumor and normal tissue sometimes that are, this will cause issues when you're trying to target it. You kill off some of the native cells that you don't want to kill. So the solution is targeting tumor-restricted post-translation modifications. So basically, after they have it in those tumors, they change they modify after post-translation, they modify it so that it recognizes only the tumor cells. So that's one limitation. This is the issue with solid tumors. You have a harder time infiltrating into the solid tumors, and so CAR T cell trafficking and infiltration is one of the limitations in solid tumors. And the solutions is they have to come up with other delivery mechanisms besides just doing full systemic. They would have to target somehow to get to just that solid tumors. And there's some studies going on, but there's not a lot of successful ones that have already been completed yet. And then you can have an immunosuppressive microenvironment, which is you're having a lot of cytokine, like I said, the cytokine release. And so it kind of suppresses, becomes very immunosuppressive. And the CAR T is not able to function as it needs to. And solution is to engineer CAR Ts that are resistant to these immunosuppressive factors and cytokines. And so that's something that's still in clinical trials. Last but not least, is once again the CAR T cell associated toxicities. It's the 23 to 46% had superphysiologic cytokine production and massive T cell expansion. So they had severe T cell expansion that was causing this cytokine release syndrome. So this, we were talking about, the cytokine release syndrome is mediated by IL-6. So a lot of times when these patients are having this reaction, you can treat them with tocilizumab and steroids, and that kind of gets it under control. There's another thing called macrophage activation syndrome, where the macrophages are just like super activated, trying to eat everything. In those cases, they need to have a different type of chemotherapy. That's the only treatment to get that under control. There's also immune effector cell-associated neurotoxicity syndrome, or they call it ICANS. Steroids are usually treated to treat it. So about 50% or so might have some kind of severe reaction that requires significant like chemotherapy versus steroids or something like that. So the conclusion, immunotherapy has changed oncology. It has revolutionized both oncology in solid tumors and hematologic malignancies. There's more research is being done to decrease the toxicity as well as increasing the efficacy. Especially in CAR T, there's a lot of trials going on, and then in ICI as well. They're studying even the ones we already have on different cancers and trying to see if it makes a difference. And as you might notice that a lot of times when you're working with oncologists, they'll call up the clinical trials and be like, my patient has tried everything else. Is there a clinical trial that I can have them join? And sometimes, that is what takes to get them better. So keep your eyes open and ears open to learn more about these immunotherapies that are the more research that are coming out, so you can stay up to date with a lot of these medications, since a lot of our patients are in that population that are getting these medications. Any questions?
So we have a question.
By the way, great presentation. You can't beat it. And I love oncology. One of the things that Boston College studies I read from them, especially a guy by the name of Thomas Seafried, something like that. Cancer works by fermentation. It does incredibly. It doesn't use oxygen. So I can kill you and your cancer still will grow. You know what I'm saying? So, and the other thing, one of the amino acids it highly uses is L-glutamine. And the other thing that uses a lot is sugar. Incredible. It needs sugar to survive. So the more, I guess obese or whatever not, or the more sugar intake you have in your life, the worse it's going to get. So dietary. And I will also suggest one more fact is microbiome. How's your GI microbiome? You know what I mean? To support all these treatment.
Great presentation. Any contradiction if they have already autoimmune diseases, like already diagnosed with autoimmune disease, or any contradiction to take vaccine since they are on immunotherapy? Do you come across any
Well, you mean cancer vaccines or just regular vaccines?
regular vaccine? I think live vaccine should be problem.
Yeah, so yeah, they do try to avoid the live vaccines, but a lot of these patients are so immunocompromised that they would benefit from the other vaccines to make sure that they stay safe.
Mhm.
But usually it's not something that we really bring up as an issue when we're giving immunotherapy if they have an autoimmune condition.
Okay.
Yeah.
Thank you.
Thank you.
Awesome presentation, Abby.
Thank you.
You mentioned that CAR T was newer. Do you know, I guess, like the likelihood of insurance companies wanting to pay for this? Do you know anything about the
Well,
financial?
I think, like I said, it's usually the last line treatment for a lot of patients. So insurance companies, if they have insurance, they already know they tried all the other ones and now they're going here. So as far as I know, insurance does cover it, but it's like you already have to try and fail all the other ones before they cover it. Also, if just to add,
Sure.
if you don't have insurance, a lot of patients are going into clinical trials, so they'll get it through the clinical trial. So that's another option for a lot of patients.
Thank you so much for your talk.
Thank you.